Great. Okay. Thank you all for being here. It is my honor and joy and excitement to introduce Dr. Khan to you all. I am a huge fan of the PEACH program. I've learned so much about PEACH and what Dr. Khan does, pelvic health, anogenital HPV, cancer prevention and screening, since joining this team. And I'm so excited that we have Dr. Khan here with her expertise and the services that she provides to all of our patients, but especially the high needs in the LGBTQ plus community. And so I'm excited to be a part of this talk and get to continue learning more from Dr. Khan. So quickly, just to share Dr. Khan's background and bio. Michelle Khan is a board certified generalist, I'm not going to be able to talk today now. Obstetrician and gynecologist, this is my own department too, with fellowship training in reproductive infectious diseases. Dr. Khan's clinical expertise is in screening, evaluation, and treatment of HPV-related diseases and prevention of HPV-related cancers. She is active in professional societies teaching national and international courses in colposcopy and high-resolution anoscopy, and formulating guidelines for screening and management for HPV-related diseases. She is enthusiastic about training more providers, like all of y'all here, in anal cancer screening to be able to expand these needed services to the LGBTQ plus community. And with that, I will turn it over to you, Dr. Khan. Thank you again for doing this talk today and being here with us.
Thank you so much, Blaze, for that kind introduction. Thank you all for being here and for your interest. I'm going to share my screen and we'll get started. And I'll give the talk, and we do have the chat. So if you have questions that come up, please put them into the chat and we'll do question and answer at the end. And disclaimer, I'm a little bit sick, so I apologize for the nasally voice today. I have no conflicts of interest to report related to this activity. However, I will be discussing off-label use of screening tests. So our objectives are to discuss human papillomavirus for HPV and cancer epidemiology. We'll review what the national screening recommendations are for screening for HPV-related cancers. We'll understand how to perform anal cancer screening and which high-risk groups to target. And I'll provide an overview of the Stanford PEACH program and how to refer to us. So to start out, HPV, human papillomavirus, is one of the most common sexually transmitted infections. It's associated with many anogenital conditions, as you can see here, ranging from warts to precancerous lesions, which are called intraepithelial neoplasia, to invasive cancer. And the HPV virus affects everywhere in the anal and genital tract, including the cervix, the vagina, the vulva, the anus, the penis, the scrotum, and also affects the oral cavity. It is the most common STI in the US, as you can see, the most prevalent, followed by herpes. When we look at worldwide cases caused by HPV, we see that genital warts are the most common condition caused by HPV, and warts are caused by the low-risk types of HPV, which are usually type 6 and 11. And after that, the most common is cervical cancer, which affects almost up to 600,000 women across the world nowadays. The one big reason for this is that a lot of countries don't have screening programs. We're lucky that we have one here. Following cervical cancer, head and neck cancers or oropharyngeal cancers are the most common cancer related to HPV, followed by anal cancer. And here you can see they break it down by sex, so female and male sex, and you can see that actually the majority of anal cancers occur in females. Next is vulvar and vaginal cancer, and the least common of the HPV-related cancers is penile cancer. When we look at US data, we see that cervix is the most common in people assigned female at birth, followed by anal cancer, followed by vulvar cancer. When we look at people assigned male at birth, we see that oropharyngeal cancer caused by HPV is the most common, followed by anal cancer and then penile cancer. The good news is that we've been doing cervical cancer screening in the United States for many decades now, since the 1940s, and the rates of cervical cancer have decreased remarkably. However, they're not zero yet, and so we continue to screen people, but we know that screening makes a difference and it does decrease cancer rates as well as morbidity from cancer. Anal cancer, on the other hand, is actually rising in incidence about 2 to 3% per year in the United States. And anal cancer is also caused by HPV, the high-risk types of HPV, and in particular, HPV-16 is the type that causes the majority of anal cancers. When we look at it by sex at birth, we can see that people assigned female at birth have higher anal cancer rates than people assigned male at birth, but these rates are rising for both groups. This was a study that I did. I worked at Kaiser, Northern California, before I came to Stanford, and we looked at the data in the population there. We looked at people assigned female at birth, and we looked at the rates over time and by age group for the lower anogenital tract cancers. And what you can see here is that cervical cancer increases in the 30s, and then anal cancer is the gray line, and you can see that that increases later in life, and it actually surpasses the incidence of cervical cancer at age 55 there. So the rates of anal cancer are higher in older women than the rates of cervical cancer. Yet we don't do any standardized screening for anal cancer at this time. When we looked at the rates divided up by age, we looked at people assigned female at birth younger than 50. You can see that cervical cancer is really the one that is the highest incidence. When we looked at anal, vaginal, and vulvar cancers, those are lower in incidence. When we looked at older than 50, you can see that the anal cancer incidence over time surpassed the cervical cancer incidence. And Kaiser Permanente Northern California does a really good job of cervical cancer screening. They have a callback program. They send postcards out to people who don't come in for their screening, and they screen every 3 years. So they're very aggressive about the cervical cancer screening, and that has really decreased the rates. So you can see here that anal cancer rates are higher. When we look at vulvar and vaginal, those are a little bit lower, although vulvar cancer is close to cervical cancer in this population. So when we talk about cancer prevention, there's different levels of prevention. Primary prevention is when we're preventing the infection or acquisition of the primary cause of the cancer, in this case, the human papillomavirus. When we talk about secondary prevention, that's trying to find and treat a precursor lesion or a precancer to prevent it from turning into cancer. And tertiary prevention is treating people with cancer to reduce morbidity and increase survival. So primary prevention for HPV-related cancers involves vaccination. In the United States, the only vaccine that's on the market currently is the 9-valent vaccine known as Gardasil 9. It protects against HPV types 6 and 11, which are the 2 low-risk types that cause the majority of genital warts. And then it protects against 7 different high-risk types that cause the majority of cancers. And these types 16, 18, 31, 33, 45, 52, and 58 cause 90% of cervical cancers. When you get Gardasil 9, it depends on what age you're given the first dose. If you're given it before the 15th birthday, you only need 2 doses. If you're given it after age 15, then you need 3 doses. And it is FDA approved for ages 9 through 45 years of age for prevention of all of these HPV-related cancers. For people of any sex, initially when it was first approved, it was first approved for females, and then males got added, but now it's approved for anyone ages 9 through 45. Now that we know that people are susceptible to these cancers, regardless of your birth sex. There's also a use of HPV vaccine that people don't know as much about. There's several studies showing that it can reduce the risk of CIN2+ recurrence. CIN2+ stands for cervical intraepithelial neoplasia. And this is grade 2 or 3 or considered cervical precancer. So CIN2+ is cervical precancer cancer. And the studies have found that the HPV vaccination can reduce the risk of recurrence of precancer in people who got treated with a relative risk of 0.45. There's more limited data on whether the HPV vaccine reduces the risk of recurrence for other anogenital H cells, for example, anal precancer, vulvar precancer. We don't have as good data to show that it's effective in that way. But for people who've had CIN2+, it does reduce the risk and it should be considered. And a recent cost effectiveness study did demonstrate that HPV vaccination after excision, which is one of the treatment methods for CIN, is a cost-effective strategy with the incremental cost effectiveness ratio of 29,000. Excuse me, per quality. So the American Society for Colposcopy and Cervical Pathology does now recommend adjuvant vaccination with the Gardasil 9 for patients with CIN2+. So what are our national screening guidelines for these cancers? We only have screening guidelines for cervical cancer at this time. We're expecting some screening guidelines for anal cancer to come out later this year. But right now we have 3 sets of screening guidelines from American Cancer Society, U.S. Preventive Services Task Force, and American College of Obstetricians and Gynecologists for cervix. We don't have any screening guidelines for oropharyngeal cancers, penile, scrotal, vaginal, or vulvar cancers. However, for vaginal cancer, people who had cervical precancer or cancer may have had a hysterectomy or removal of the uterus, and they are often getting surveillance tests, which are vaginal surveillance tests, since they no longer have a cervix. So just to show you the screening guidelines for cervix, the most recent is the American Cancer Society, which was published in 2020. They recommend starting screening for cervical cancer at age 25 and performing primary HPV testing, which is an HPV test by itself every 5 years, or you can also do a pap test or cervical cytology every 3 years, or a cervical cytology with HPV co-test every 5 years. The U.S. Preventive Services Task Force and ACOG recommend starting at age 21, and their recommendations are any of the 3 options of pap or cytology every 3 years, pap every 3 years for ages 21 to 29, and cytology plus HPV testing, which is called co-testing, every 5 years, or doing the primary HPV test, so the HPV test by itself every 5 years. All of these societies do recommend stopping screening at age 65 if cessation criteria have been met, which includes having either 3 consecutive negative cervical cytologies or 2 negative tests with HPV being negative in the past 10 years, and with the most recent one being in the past 5 years. And they also say that the patient should not have been treated for precancer in the last 25 years. So this is a group of people who work across the United States, and we put together an effort that took a few years to go through and is now going to be published very soon. We saw that there's many misconceptions and barriers to screening for HPV-related cancers in LGBTQ plus populations. And there was really no guidance out there on who to screen, where to screen. And so providers were looking for some type of guidance for sexual and gender minority populations. Some examples of the barriers are there's a lot of myths that women who have sex with women do not need cervical cancer screening because they're not at risk. Transgender masculine patients who still retain their uterus may not be getting screened due to discomfort or dysphoria with the pelvic exam. And then transgender non-binary patients may not come in for health care due to stigma and prior bad experiences with the medical system. And men who have sex with men and transgender female are at high risk of anal cancer, but there are currently no screening guidelines. So we wanted to review the literature and come up with guidelines for screening in these populations. And this is what we are recommending. And for cervix, we're recommending following the national guidelines. For anal cancer, we're recommending screening in high-risk groups, which include people living with HIV, ages 35 and older. And I'll show you later some data to parse out why these groups are at higher risk and what their incidence rates are. So starting at age 35 for the people at highest risk and 45 for people that are at high risk, but not as high as the people starting at 35. And the group really at the highest risk is people living with HIV who identify as men who have sex with men or transgender female, have the highest rates of anal cancer and high-grade anal dysplasia. So that's the group you want to start screening at age 35. Other groups at high risk are people living with HIV who may not identify as men who have sex with men, people living with HIV who are assigned female at birth, people who've had a history of vulvar precancer, which is HSIL, high-grade squamous intraepithelial lesion, or vulvar cancer are at very high risk of anal cancer, and some other groups with high incidence, including immunosuppressed populations. We do recommend considering an annual dental exam for people who are increased risk. There is no screening test currently for oropharyngeal cancer. And so asking the dentist to do a visual inspection and palpation to look for any abnormalities is really the only screening method available at this time. For vaginal cancer, it's not a very common cancer, and so it's not recommended to do screening primarily for vaginal cancer, but in people who've had cervical precancer cancer, then it is recommended to do surveillance testing in the vagina. And vulvar cancer also is not a very high, doesn't have a very high incidence, and so it's not recommended to do screening in the general population. For people at higher risk, we recommend doing a visual inspection of the vulva. Same thing for penis and scrotum. Not a very common cancer, but people at higher risk who've had precancers in other parts of the anogenital tract should have at least a visual inspection. So what are some risk factors for anal cancer? We already touched on a few. Having infection with human immunodeficiency virus, HIV, is one of the biggest risk factors. It just allows the HPV virus to thrive in the body and cause the changes that can lead to precancer and cancer. Immunosuppression, non-HIV related, is another risk factor. So patients who've had particularly solid organ transplants are at higher risk. And the length of the immunosuppression seems to play a role in the risk level as well. So people who've had a transplant for more than 10 years are at higher risk than people who just got a transplant. Sexual gender minority status, we talked about men who have sex with men and transgender female are groups at higher risk. And people who've had lower genital tract HSIL or cancer of other sites, including vulva, vagina, cervix, would be at increased risk for anal cancer. Smoking is a big risk factor for the HPV-related cancer. It allows the HPV virus to persist in the body and to be more likely to progress from precancerous lesions to cancer. Having a history of anal warts is another risk factor in some of the epidemiologic studies. And having multiple sexual partners is really a proxy for getting the human papillomavirus, or HPV. History of anal intercourse, I put in parentheses. It is a risk factor in some studies, not as much in others. It's really more about exposure to the HPV. When we look at people assigned female at birth, we see that there are higher rates of HPV in the anus than in the cervix, which a lot of people are surprised by. And the degree of immunosuppression is related to the prevalence of HPV. So you can see that people with very suppressed immune systems, CD4 less than 200, have very high rates of anal and cervical HPV. So this is a meta-analysis that was published a couple of years ago that summarized all the data on anal cancer to look at all of these different risk groups and come up with some summary incidence rates to help us understand better who we should be screening. And you can see on the risk scale that people living with HIV who identify as men who have sex with men have the highest incidence rates of anal cancer. That value is 85 per 100,000. Whereas in the general US population, the rates of anal cancer are on the order of 2 per 100,000. And you can see that the age plays a role as well, with the greater than 60 years old living with HIV having rates of 108 per 100,000. Men who have sex with men who are HIV negative have an incidence rate of 19 per 100,000. So still markedly above the general population, but a lot lower than the rates in MSM living with HIV. When we look at males who do not identify as men who have sex with men who are living with HIV, we see that the rates are 32 per 100,000. When we look at females living with HIV, the rate is 22 per 100,000. And then I mentioned before that having had vulvar precancer or cancer is a risk factor as well. And you can see here that the rates are elevated. Incidence rate is 48 and 42 per 100,000 of anal cancer in these groups. When we look at non-HIV immunosuppressed, we see that people who've had a solid organ transplant for greater than 10 years that are female have rates of 50 per 100,000 of anal cancer. So quite high. And when you go, when you look at lower, less immunosuppression, less years of immunosuppression, the rates are a little bit lower, but still elevated above the general population. So a couple of years ago, there was a trial that was in progress that got halted because they found high success rates of the treatment. And this study was called the Anchor study. And it's really going to change this field moving forward. So I want to tell you a little bit about that study. It was published in the New England Journal of Medicine last year. And it was a phase 3 randomized controlled trial. It was multi-centered at 25 different sites in the United States, and it included people living with HIV ages 35 and older who had biopsy confirmed anal HSIL, which is the same as anal precancer. They had 46 people who were randomized to either getting treated for that anal precancer or getting actively monitored with high resolution anoscopy every 6 months. So just following the precancer, but not treating it. The participants were followed for a median of 25.8 months, and the trial was stopped prematurely in 2021 for safety. So they found that the rate of progression to cancer was 57% lower in the treatment group. And so they found that treatment does make a difference. And they didn't continue the trial because they knew that that would allow the people in the active monitoring group to go on to develop cancer. And here you can see the rates and the time to progression to anal cancer. The blue line is the active monitoring group. Excuse me. The blue line is the active monitoring group, and the red line is the treatment group. And you can see the active monitoring group had higher rates of anal cancer over the course of the study. There was another study that was performed in the Netherlands that also has shown that that screening makes a difference and decreases mortality from anal cancer. This was a nationwide cohort study. And here you can see the Kaplan-Meier estimates of patients who got screened and patients who did not get screened, and what the mortality was over time. You can see that the red line is no screening and the blue line is screening. And the top line is anal cancer related mortality. So you can see there was a significant difference between the people who got screened and the people who did not get screened. They also found that in the people who got screened, there were more early cancers that were detected than in the people who did not get screened. So even if screening doesn't prevent cancer, it can detect cancer at an earlier stage, which can help to improve mortality rates. So how do we screen for anal cancer? The approaches include what I have listed here, including an anal cytology or anal pap test, an anal high-risk HPV test, which is a test for one of the 13 or 14 different types of high-risk HPV, with 16 and 18 being the worst two types, but there are 12 other types that can cause cancer. And so the tests that are out there generally test for all 14 of those types. And then there's digital anal rectal exam, which is an exam, a non-molecular test, but an exam that can pick up cancers at an early stage. And then high resolution anoscopy with biopsies is a diagnostic procedure to take a biopsy and get a definitive diagnosis, which is the histology showing whether or not there's any anal precancer or cancer there. And for anyone who's familiar with colposcopy, which is looking at the cervix with magnification for people who've had abnormal cervical cancer screening tests, HRA is the anal equivalent of that. There was a systematic review and meta-analysis of these screening tests, particularly cytology and HPV testing among different risk groups, which has given us some estimates for sensitivity and specificity for these tests. Anal cytology is performed with a synthetic swab. It can also be performed with a little brush. In our clinic, we tend to use the swab. It can be polyester, it can be rayon. Any synthetic swab, you don't want to use cotton. There is a learning curve to get an adequate sample. Sometimes you have to put a lot more pressure than you think to get a sample, and you may get a lot of unsatisfactory results when you first start out doing it. But over time, people can improve their cellular collection. The sensitivity of anal cytology is 81% and specificity is 62%. You may be surprised by these numbers, but the sensitivity of the cervical cytology or cervical pap smear is only about 65 to 70%. So cytology in general is not the test with the greatest sensitivity. But when you repeat a test like this over time, it improves the sensitivity. This is how you can order anal cytology in EPIC. The order is called anal pap. And you would, this is a new order since December. It used to be under just the general pap and you would select anus, but now there's actually an anal pap order. You can put in their clinical history and you can select whether or not you want to do HPV testing along with the cytology. And this is the vial that we use to put the specimen in. It's the same vial that we use for cervical cytology. What you're trying to sample with the anal cytology is you're trying to sample the squamocolumnar junction, which is the junction between the rectal columnar epithelium and the anal squamous epithelium. And that's the location that most anal cancers and anal precancers tend to develop and is most susceptible to HPV. And so going into the anal canal, approximately 4 to 5 centimeters to try and sample that tissue is what we're aiming for when we're trying to do the cytology. When we look at the performance of anal high-risk HPV testing, which is also sent from the same type of specimen that you send the anal cytology, we see that it has a much higher sensitivity of 92%, but the specificity is lower. It's about 42%. When we look at anal co-testing, which is a combination of anal cytology and high-risk HPV testing, we see that the sensitivity is 93% and specificity 33%. So the sensitivity doesn't change that much when you add the cytology to the high-risk HPV testing, but the specificity does drop a little bit. And this is the summary of the performance estimates of these tests in different populations from that meta-analysis. As you may know, the performance characteristics changed with the prevalence of the disease. So in all people, the sensitivity of cytology is 81%, and of HPV testing is 92%. The specificity of cytology is 62%, and the specificity of HPV testing is 42%. When we look at the population, people living with HIV who have higher risk and higher prevalence of anal precancer and cancer, you can see the sensitivity is a little bit higher, 84%, and the specificity 60%. HPV testing, the sensitivity is 94% and specificity is 35%. When we look at the group with the highest incidence of anal cancer, which is MSM living with HIV, again, the sensitivity is around 85%. So it's a little bit higher in a group that has higher prevalence. And this is in women, the sensitivity is 66% and specificity 82%. So it definitely performs a little bit differently in different populations. This is an MSM not living with HIV. You can see the sensitivity is 57% for cytology, and for HPV testing is 76%. So let's just talk for a minute about the digital anal rectal exam, which is called DARE. DARE is a test that I always perform after I've done the anal cytology collection. And it involves inserting a gloved lubricated finger into the anal canal. And you want to insert at least 4 centimeters. And then doing a 360-degree sweep to palpate for any lesions, masses, nodules, or irregularities. And you want to make sure to palpate not just inside the anus, but also the distal canal and the perianus, where you can also get cancers. DARE is a simple test to perform after you've done it a few times. It's not very hard to do. It's inexpensive, and there's no like lab test involved. And it does have the potential to pick up early cancers, which if anal cancer is detected early, there's a potential for better outcomes with treatment and decreased morbidity and mortality. We don't have great estimates for the sensitivity and specificity of DARE. There's not a lot of studies in the literature on DARE. So coming back to our incidence rates, looking at the high-risk groups, I want to just talk briefly about who we should consider screening for anal cancer. And the International Anal Neoplasia Society is a group that will hopefully be releasing screening guidelines later this year. But their preliminary recommendations are what I have listed here. And that's to screen starting at age 35 in MSM and transgender women living with HIV, to start at age 45 for women living with HIV and non-MSM males living with HIV, as well as HIV negative, MSM, and transgender women. They recommend starting within a year of diagnosis for people who've been diagnosed with vulvar, HSIL, or cancer, and for people who've had a solid organ transplant to start screening 10 years post-transplant when their risk is higher. In terms of other groups that are at higher risk, but not as high risk as the prior slide, they recommend shared decision-making at age 45 for people who've had cervical or vaginal cancer or precancers, for people who've had perianal warts, so warts on the outside of the anus, but not on the inside, for people who've had HPV-16 positive tests on their cervical cancer screening that has been persistent more than a year, and for people with other immunosuppression, such as rheumatoid arthritis, lupus, Crohn's, who are on systemic immunosuppressive medications. Again, these are preliminary recommendations that this group sent out to the membership, but the final recommendations will be hopefully published later this year. So for people who get screened and have an abnormal test, what do you do next after that abnormal test? We recommend high-resolution anoscopy, which is a diagnostic procedure involving examination of the anal canal and perianus using magnification. We use vinegar, a dilute solution of acetic acid, and Lugol's iodine, which is a potassium iodide solution, to help identify lesions. And then if we see lesions, we take a biopsy using a 2mm forceps. And this procedure can be performed in the office. We do offer oral sedation, and for patients who can't tolerate it, we can go to the operating room to do the procedure. Again, this is the anatomy of the anus, and we're aiming to look at the squamocolumnar junction when we do the HRA, or high resolution anoscopy, to be able to visualize it all the way around and find any lesions and biopsy them. So here's some pictures of HRA. You can see here, this is the squamocolumnar junction. This red tissue is the rectal epithelium, and this pinker tissue is the anal squamous epithelium. So the rectal epithelium is columnar, it has a lot of glands. It's more vascular, and the anal tissue is squamous, it's more smooth and shiny. And here you can see, this is the iodine solution that we use to stain it. And when it stains brown, it's more normal. The anal tissue picks up the iodine stain, but the rectal tissue does not. So we use the iodine as a secondary stain to help us identify biopsy sites or to show margins of a lesion for treatment. Here's another example of HRA. This is an anal condyloma. You can see it's a raised lesion. It's a little bit whiter when we put the acetic acid on. And that's a lesion that we can easily treat with ablation. Here's another example of an anal condyloma. They can look a lot of different ways. They can be soft, they can be harder. They oftentimes will have a lot of vessels like what you can see here. And it has that like kind of papillomatous kind of cauliflower appearance. Here's an example of a high-grade lesion or anal precancer. It's oftentimes flat. It turns white with acetic acid and has some characteristic findings, some vascular changes, some gland openings that help us to identify it. And here's an example of a perianal HRA. This is looking on the outside. We always look on the inside and the outside. And you can see there's several hyperpigmented lesions kind of scattered around the perianus, and these were all precancerous. So who should get the high resolution anoscopy once you've had the screening test? And these are the preliminary recommendations from the International Anal Neoplasia Society. Anyone who has ascus or atypical squamous cells of undetermined significance cytology or worse, if they have ascus HPV positive, then they should be referred. If they have a HPV negative with ascus, then you could repeat the testing in 12 to 24 months. You don't have to send them immediately if the HPV is negative. If they have any high-grade cytology, so HSIL or ASC-H, which is atypical squamous cells, cannot rule out high-grade, regardless of their HPV result, that those are precancerous changes and should be evaluated. Anyone who has HPV 16 positive, since 16 is the type that causes the majority of anal cancers, we do recommend high-resolution anoscopy for people who have a positive test. And then anyone who has persistent symptoms or an abnormal DARE exam, something was felt on DARE, should have a high-resolution anoscopy for further evaluation. People with symptoms should initially be treated. You know, there are things that are more common than anal cancer, like hemorrhoids, anal fissures, STIs. But if it doesn't get better after conservative management, then they should be referred for further evaluation. So I just want to tell you a little bit about the PEACH program, which stands for Prevention and Education of Anogenital Cancers and HPV-associated diseases. We're located in Redwood City at the Stanford Pelvic Health Center, which, if you haven't been there, it's a multidisciplinary center where patients come and are able to see a variety of specialties, including gynecology, colorectal, gastroenterology, urology, pelvic floor physical therapy. In PEACH, we offer consultation on anogenital dysplasia. So we see patients that have had abnormal screening tests or have like a longstanding history of dysplasia and are being followed. We do colposcopy of the cervix, vagina, and vulva, and high-resolution anoscopy. We offer treatment for warts as well as precancers. We offer topical treatments as well as surgical treatments. And we do have LGBTQ plus healthcare at the Pelvic Health Center, including the PEACH program. And Dr. Kavita Mishra also has her practice there, where she offers gender-affirming surgery. We also offer HPV vaccination there and do office procedures and surgeries. But we do have the capability to take patients to the operating room if they need anesthesia. This is my wonderful team. We have nurses, MAs, a clinic coordinator, and then Amy Wong is my wonderful nurse practitioner who is just starting to do high-resolution anoscopies as well. And so we'll be able to increase our access for HRA. I did want to briefly show you how to refer to us because it's not intuitive. You have to refer to the Pelvic Health Center. So in Epic, it's referral to Pelvic Health. And then under provider, you would type my name and then type in the diagnosis. For a location, it's the one in Redwood City. And then for diagnosis, you would type in anal dysplasia or vulvar dysplasia, whatever it ends up being. And then put the reason that you're referring them. Thank you, everyone, for your attention. It looks like we have about 10 minutes for questions.
There's a couple questions in the chat. So Craig asked, is it recommended for patients who receive Gardasil 4 to also receive the new vaccine?
That's a great question. The CDC does not currently recommend revaccinating, with the rationale being that if they got Gardasil 4, they're protected against the types that cause the majority of these cancers. When they added the other 5 types to Gardasil 9, those cause 20% of cervical cancers. And so they wanted to, it was primarily designed to increase the coverage for cervical cancer. But the CDC at present does not recommend revaccinating.
And then Craig also asked, and this is in regards to the ANCHOR study, I believe, were the participants living with HIV undetectable, not on ART, or unknown?
That's a great question. I believe that most of them were well controlled for their HIV status, but I'd have to look back at the study to be sure.
Thank you so much for this talk. This was really informative. I really enjoyed it. Thank you, Dr. Khan.
Thank you. Thank you for your questions.
Yeah, I was going to echo that, Dr. Khan. I know you're not feeling well, so thank you so much for doing this today. But as always, I just found everything so enlightening, and especially the breakdown of all the rates. And I'm excited to hear the screening guidelines are coming out. So do you know the time frame on that piece? I know you talked about it a little bit, but.
Well, I don't, and we've been waiting for them for a while, but that society is having their annual meeting in November, and there's a talk on the agenda that is titled, "Now that the screening guidelines are out, what are we going to do?" So I'm assuming it'll get published before November, which is exciting. And our article on screening in sexual gender minority populations is going to be coming out in October.
We got another question in the chat from Daniel. Excellent review. What is data on HPV vaccination efficacy in HIV positive patients? Also, use of vaccination in solid organ transplant patients?
Great question. So for HIV positive patients, they do have lower immune responses in the studies to vaccination in general, but there has been still good efficacy against disease. For transplant patients, it seems to be that getting vaccinated before the transplant is ideal. But it could still be considered after the transplant.
Dr. Khan, I was wondering about, this is something I don't see a lot in community spaces being talked about yet. Places like Pride or community centers. And I wonder, what's a good way to get I know this is a convoluted question in a way, but how do we get this message out there? How do we make sure that patients know, especially the anogenital screening recommendations and the engagement? What would be your strategy it's a sensitive thing to talk about. I think Peach is a great name because it makes it a little bit more approachable, but how do you get those conversations going with people? How should we be all in our spaces when we go out trying to advocate for people to be aware of these services and when they need to be engaging in them?
Yeah, that is a complicated question, and part of the reason for that is that we don't have enough providers that do this work. So I think that's looking at the screening guidelines that will be coming out and who they're saying to start screening. Part of the rationale is that we don't want to say screen everyone and then there's no one to actually do the screening and evaluation. So they're trying to target the highest risk groups. But I think raising awareness about it. The ANCHOR study had some really cute marketing materials when they were trying to recruit patients, like little cartoon figures of butts and butts of all different shapes, sizes, colors. I think it is an uncomfortable subject to talk about, but it is really important. And I had mentioned earlier in the talk that like females have the highest, or the majority of anal cancers are in females, and most females are not getting screened for anal cancer, or like don't even talk to their gynecologist or doctors about if they feel something different back there. And I think the same applies to LGBTQ populations, where they may not feel comfortable talking to their provider about the symptoms that they're having. So I think we probably need to be better as a medical community about asking about any symptoms, and maybe offering a DARE at any kind of annual exam to try and elicit any symptoms, but also to start doing screening and raise awareness about it. There's not enough people that do HRA, and so anyone who's interested, please come talk to me. I think that we need to just expand our services in general. We're lucky in the Bay Area, we have a lot more options for places that do this compared to some states have no one that does anal cancer prevention, but there's still not enough providers. So it's something that I think we could maybe even have a booth at Pride event and talk about cancer screening. Could be one way to start.
Thank you, Dr.
That for next year.
Thank you, Dr. Khan. And we got another question from Craig. Can anal cytology/histology be performed by trained RNs or only LIPs/APPs?
I'm not sure what LIP is. I know APP is.
That's licensed independent practitioner, like doctors, DOs, MDs. Yeah.
Okay. So it can be performed by RNs, and actually in our positive care program at Stanford, Jimmy is the RN there is doing the anal cytologies. So it's something that can be performed by RNs. I worked at Kaiser before coming to Stanford, and many years ago at Kaiser, they had an RN even doing the high resolution anoscopies. I don't know of any RNs currently in the field doing the high resolution anoscopies now, but certainly APPs are doing them. And one of my mentors was an APP, or is an APP, and was the president of the International Anal Neoplasia Society.
That's really exciting to hear. Hopefully that helps expand coverage, at least for the collection process.
Definitely, yeah. I would love to expand screening in primary care settings, and then referral to our program for people who have abnormal results. So if you have any ideas on how to reach out to the primary care settings, or who I can talk to, I would love to hear that.
Really great talk. This is Marvin Langston. I know the goal at the moment is kind of this expansive, like trying to have a more expansive screening. But I'm wondering about, is there any pushes towards more risk stratified screening in terms of, especially for MSM populations, when it comes to sexual activity? I don't know if that's something that folks have been having conversations about or not, or if the mantra right now is just, everyone should be getting screened.
I mean, it's a good. Oh, there's an echo. It's a good question. And there's a study from Australia called SPANK, Study for the Prevention of Anal Cancer. And they found that having receptive anal intercourse, people who were the bottom in relationships had higher rates of anal precancer compared to people who were tops, but there's still risk for people who are not currently practicing receptive anal sex. I'm assuming, is that what you're getting at in terms of stratifying risk amongst populations?
Yeah, it was positioning, but it was also in terms of of sexual activity. So for example, you know, there are some folks that are in long-term committed relationships that aren't having, outside sexual activity. And so I'm just wondering about that too.
Yeah, definitely. So the HPV exposures will increase with the number of partners that you have. However, you know, I think the risk, the street screening is stratified based on these risk levels that they've identified. But certainly if someone's in a monogamous relationship, not having any new exposures, and they've had negative testing, then I think it's reasonable to not do as frequent screening. So HPV isn't like just about the current sexual activity. Like everything in the past can come into play. And so I think it's important to get a really good sexual history. And we do that at our initial consultation visit to figure out what the risk is and if there's any potential risk going forward. And yeah, people who might be not having new exposures may not need to be screened, or the screening may not need to be done as often.
I know we're coming up on time. One note that I'll have on this last point, I know that I've learned from Dr. Khan that also in that risk screening, any kind of symptoms or discomfort in that area can be another thing that might heighten screening needs. I learned that from you, which I think is great. And I always try to encourage people on that piece too. Even in monogamous relationships, if you're having any discomfort in that area or some of those symptoms, that could be another indication for that stratification of screening need. And now we're at the end of our time. So two things. One, to everybody that's here, we don't have a next talk lined up. We'll be engaging some folks and reaching out, but we also wanted to invite you, if anybody here has an interest in a subject or a talk or a program that's at Stanford that you'd like to learn more about, please send your ideas or recommendations to Peyton or myself. Mine's blazebush@stanford.edu. Peyton is there in the Zoom, K98@stanford.edu. And then I would like to turn it over to Dr. Khan, if you'd like to have the last word for us to leave with.
No, I just want to encourage everyone to consider screening in the groups at high risk, and feel free to send me a message with any questions that come up after the talk. I think someone put in the chat, Daniel, that there was a recent paper. I would love to get a copy of that. And thank you all for being here and for your interest.